The capsular lens, according to Ong, is an artificial lens, which is completely fixed in the posterior chamber of the eye by the remnants of the original crystalline capsule. This artificial lens occupies the anatomic position of the original lens. So the capsular lens has to be implanted into the posterior chamber in the remnants of the capsular pocket of the original lens. For this purpose, the usual technique for extracapsular cataract extraction was refined and further developed in the following respects. First, the anterior capsulotomy was adjusted to form an upper and lower capsular pocket. Secondly, a bimanual aspiration and irrigation method was developed to remove all visible tissue fragments. And thirdly, a special implantation procedure was conceived for atraumatic and correct insertion of the lens in the capsular pocket. By means of the modified capsulotomy, of the bimanual aspiration and irrigation method developed, the old lens is removed and the artificial lens is positioned through the special implantation procedure. Because the lens has to be completely fixed by the remnants of the original capsule, a specific approach to the anterior capsule is imperative. This is done in 3 steps. In the first step, a series of punctures is made from left to right in the form of a concave line at 12 o'clock. In the second step, a series of punctures is made from left to right in the form of a long convex line, almost parallel to the lower margin of the pupil. And in the third step, both series of punctures are interconnected from bottom to top, after which a large part of the anterior capsule has become loosened. The operation starts by forming a limbus-based conjunctival flap. Post-operatively, this flap acts as a dressing for the incision. Careful cauterization of the area to be incised is essential for a clear operation field. In this case, routine surgical diathermy is used at low frequency. Subsequently, an oblique incision is made at the level of the limbus, up to 3/4 of the thickness of the corneoscleral zone. In this incision, 2 10-0 nylon sutures are pre-placed. At 12 o'clock, a puncture is made, through which the anterior capsulotomy is performed under an air bubble. The surgical technique proceeds as follows. As the first step, the anterior chamber is gradually filled with air through a straight puncture needle. With the sharp beveled side of the puncture needle pointing downwards, the upper series of punctures is then made in the anterior capsule from left to right under the air bubble, which produces the upper capsular pocket. Subsequently, the puncture needle is bent to size for the second step. With the bent puncture needle, the lower series of punctures is then made in the anterior capsule from left to right under the air bubble, thus producing the larger lower capsular pocket. Preparatory to the third step, the puncture hole in the corneoscleral zone is now widened with a knife to the left and the right. Eventually, the two series of punctures are connected at both ends with the capsule scissors by means of two cuts, first left and then right, so that a large part of the anterior capsule is loosened. Next, the incision is widened with two Castro-Viego scissors. The pre-placed sutures are pushed aside. Extraction of the cloudy lenticular nucleus with part of the anterior capsule is done in the usual way by exerting light pressure on the sclera near the limbus at 6 and 12 o'clock. Once the widest portion of the lens nucleus presents itself in the pupil, the nucleus is grasped laterally at 2 o'clock and removed with a cartwheel movement. By means of bimanual aspiration and simultaneous irrigation of the anterior chamber with balanced salt solution, all visible cortex remnants are then removed. Finally, the posterior capsule is polished smooth. It is essential to remove all visible cortex remnants. The capsular pockets and the posterior capsule too should be entirely clean. Experience has shown that it is necessary, following complete toilet, to polish the posterior capsule for a short time, even if it appears clear. This further reduces the chance of the formation of after cataract. The implantation procedure comprises two insertion maneuvers in the anterior chamber, whose shape is maintained by continuous irrigation. With the initial insertion maneuver, the large loop of the lens is pushed into the lower capsular pocket. With the second insertion maneuver, the upper loop of the lens is placed in the upper capsular pocket. With the first insertion maneuver, the lens is grasped at the upper loop with the lens forceps. With its convex side down, it's then introduced into the anterior chamber. The large loop slides obliquely through the pupil towards the posterior capsule. In this oblique position, the loop, riding on the posterior capsule, slides further into the lower capsular pocket. The upper loop is then laid on the iris under the limbus. The two pre-placed sutures are tightened. The second insertion maneuver is begun by introducing a blunt-hooked irrigating cannula. This fine hook, which is inserted into the fixation hole in the lens, can hold and direct the lens. Subsequently, an aspiration cannula is introduced, which shifts the pupillary margin upwards. With the irrigating cannula, the lens is first slid downwards and then to the center. Thus, the upper loop in turn rides upon the posterior capsule into the upper capsular pocket of the lens. After disengaging of the irrigating hook, the lens spontaneously centers in the remnants of the original capsule of the lens. The lens is placed at the correct depth with gentle pressure on the center. At the same time, carbachol is injected for adequate meiosis. The result is an artificial lens which in the posterior chamber is completely fixed by the remnants of the original capsule. This lens, however, is not merely located in the posterior chamber, but also reconstructs the posterior chamber into a fully functional part of the eye. This is proven by the slit-shaped clearance between the implant lens and the iris, and the free dynamic pupil. As a result of the anatomic position of this capsular lens, any surgical procedure remains possible in this eye operated upon, such as corneal transplantation, glaucoma surgery, after cataract decision, and surgery for detachment. The incision is closed with a single running shoelace suture of 10-0 nylon. The two pre-placed sutures are then removed to limit surgical astigmatism. Finally, the conjunctiva is closed with a single running 7-0 catgut suture. Routinely, dexamethasone is injected subconjunctivally into the fornix at 6 o'clock.